It was based on the function of that side of the heart. So again, to review, left side ventricular failure will produce decreased cardiac output and pulmonary congestion because that is the main function of the left ventricle. Its job is to pump blood out of the aorta as well as to receive blood from the pulmonary circulation. So therefore, if it fails, then those two functions will be affected. That's why they result in these symptoms. So signs and symptoms of left-sided heart failure will be, of course, decreased cardiac output, and as well as there will be pulmonary congestion because that is what it does. And right side, since the job of the right ventricle is to receive blood from the systemic circulation from both the upper and the lower parts of the body, that's why they result in these signs and symptoms. Okay? They have systemic congestion because blood is unable to return and leave the right side because the blood will just be stagnant there because the right pump is failing. Let's go to diagnosis now. If you recall the same chart, 35.1 and 35.2, the patient with heart failure comes in with shortness of breath. Now, there will be a countless number of disorders that can result in shortness of breath. There are cardiac and non-cardiac causes, namely, it's not just heart failure. It could be a heart attack. It could be a valve problem. It could be a dysrhythmia. It could also be pulmonary. Let's say somebody who has COPD or asthma, for instance, or somebody who has a pulmonary embolus, or somebody non-pulmonary, non-cardiac in nature. It could be psychological. Somebody comes in with serious nervous breakdown, for instance, or panic attack, or just simply anxious about something. Or maybe they took too much drugs, for instance, had too much cocaine, they had tachycardia as a result. So they will all present with shortness of breath in the ER. So you have a short window and we cannot wait for one lab test to come back and then do another one. So chances are when the patient comes in with these symptoms, the ER doctor will have a set of routine orders that they will do when the patient comes in with shortness of breath, a set of symptoms. They know already what to draw. So there will be these regular orders here. One is we'll do an electrolyte panel. Can also do chemistry. Chemistry will include not only electrolytes, but also kidney function, liver function as well. And we will also draw, because anemia, severe anemia can also cause shortness of breath because there's impaired oxygen delivery to the tissues. Or a patient may be in fluid overload. Okay, so we will do chemistry as well as CBC. And since it will also resemble, like I said, the pulmonary embolus, so we will also draw D-dimer levels to cover clotting panel for the patient. And one specific blood test to evaluate heart failure is BNP. What was BNP again, which we discussed 2 weeks ago in chapter 33? Anybody? What is BNP? What produces it and why?
The tissue in the lungs. I meant not lungs, I meant the heart. Sorry.
Right, so which particular part of the heart, Jenna?
The right atrium. No. Yes. Is that wrong?
That would be the ANP. So the BNP, can you read this again? But you're correct. It's produced by the heart. So
As discussed earlier, it is part of the body's response to decreased cardiac output from either left or right ventricular dysfunction. Okay, so right ventricle or left
all
ventricle.
right, so these are produced by the ventricles. Why did the ventricles release BNP again?
Because if the preload is, if the tissue, if the muscle is stretched too much because of increased preload, then it releases the BNP.
Correct. All right. So what are the two effects again? Very good. What are the two effects of BNP? Why did the ventricles release these when there is overstretching of the ventricles? What are the effects of BNP? So this is like a cry for help. This is actually a self-preservation response by the ventricles of the heart. It knows that it's in trouble because there is now a large amount of preload causing the ventricles to overstretch. So what are the two effects of BNP? Why did the ventricles release it? Remember in chapter 33, we said, chapter 33 mentioned that BNP has effects opposite of aldosterone.
Is it part of the compensatory mechanisms?
Okay, so this is the heart's compensatory mechanisms. Again, what are the two effects of BNP? Why did the heart release it? Why did the ventricles release it?
To lower blood pressure?
Not really. So again, the trigger here is an increase in preload. It's not like the patient drank a lot of water or received a lot of IV fluids. It's not that. It's because the patient's heart is failing. So the pump is failing. It's not able to get rid of blood that it's supposed to. It has one job, again, it's to pump blood. Receive blood, pump it back out. Receive blood, pump it back out. 60 to 100 times every minute, 24/7, 365 days a year. That's its only job. So if there is now an increase in preload, which it obviously it cannot handle, therefore the response of the ventricles is to release BNP. What are the two effects of BNP?
Vasodilation.
One, very good, vasodilation. And what is the other one? To get rid of the preload. What will it do? So vasodilation will decrease afterload. Very good. What is the other one? So remember we talked about this extensively 2 weeks ago. There are three elements in perfusion. We have heart, the pump or the contractility. Then we have preload and afterload. What did you say needs to be done to the preload and afterload? Do we increase it or do we decrease it in the presence of heart failure?
Decrease.
Decrease it. So you already have vasodilation, which decreases afterload. How does BNP decrease preload? By causing what? Again, the clue here is it's opposite the effect of aldosterone. So if aldosterone causes reabsorption of sodium and water.
Would it increase urine output?
All right, very good. So it will do the opposite. It will cause diuresis. So two effects of BNP is diuresis and vasodilation. Therefore, it lowers preload, lowers afterload. However, obviously, this is not effective in normal setting, in a normal condition. Yes, it may be, but in the setting of heart failure, the use of BNP is therefore useful to diagnose heart failure because there's no other organ in the body that produces BNP, only the of the heart. So they're making it exclusively a good marker of heart failure. To draw BNP, if it's high, there's only one decision. There's no other. You can rule out all of this, so the doctor can make a diagnosis that it's not PE, it's not a heart attack, it's not arrhythmia, it's not COPD, whatever else is the cause. We have a high BNP, it's only release line, the ventricle, therefore we make a definite diagnosis of heart failure. And in the same way, because the level of VNP is parallel or corresponding to the stretching, meaning the higher the VNP, the worse the patient's heart condition is. Are you with me so far? So therefore, we also use BNP to evaluate the patient's response to therapy. Meaning, as we give the patient treatment, which is our next topic, of the drug therapy now to treat heart failure, can we use BNP to evaluate the effects of heart failure? Amen.
It was breaking up really bad.
You're breaking up.
All right, let me switch to. All right, so we said that since no other organ of the body produces BNP, that would make BNP a specific marker for heart failure. Meaning, if the BNP is elevated, then that means it will rule out all other causes of shortness of breath or chest pain. So the patient's symptoms here are specifically related to heart failure. And because of that same reason, we can also use BNP to evaluate response to therapy. So as soon as we start giving treatment to the patient who is admitted for heart failure, if we use BNP to diagnose it, we can also use the same BNP levels in order to evaluate the response to therapy. Can you read this, please, Mr. Mitchell?
In the ambulatory care setting, BNP trends may be used over time to guide ambulatory care treatment. A therapy is optimized, BNP levels, as therapy is optimized, BNP levels decrease.
Okay, so don't misinterpret this as only in the ambulatory care setting, okay? It's also the same as in inpatient care setting, right? There's really no difference. Okay, so here it rules out heart failure as the cause of acute dyspnea. You can easily distinguish whether this patient who is short of breath, gasping for air, is a pulmonary condition or is a cardiac condition. So using BNP, you can easily please take care that consider renal disease, because renal disease excretes everything, right? So everything in our blood will be excreted by kidneys. So if there is kidney failure or kidney insufficiency, consider that it may cause a falsely elevated BNP levels as well. In the outpatient, since is heart failure a acute condition only, or is there also is it also a chronic condition?
Chronic.
All right, this is a chronic condition. A chronic condition with acute exacerbations. Is my audio?
I think it was better when you didn't show your face.
Yeah, I think when you showed
Yeah, once you turned your video off, it got better.
Yeah. So maybe we should not show our faces too.
Can you hear me fine?
It's better now, but it was going in and out a few minutes ago.
Yeah, you Gucci now.
Because it's already using, because I bought a new microphone, and it's using this microphone that's new. They're
Now
working.
Right now.
I think it's your Wi-Fi.
Yeah, I think it's internet connection. Because your voice is clear.
Okay.
This
All right,
one's
so
okay.
just interrupt me if I am disappearing, okay? Now,
All right.
since this is a chronic condition, and would we prefer that we wait until the patient already has pulmonary edema or signs and symptoms of heart failure before we treat them?
No.
We just wait, Like you were the doctor, will you just wait in the office for a phone call? Anytime now, my patient will call and he's already in heart failure, decompensation state, and then I'll go to the hospital. Is it like that?
No.
Of course not, right? So you want to monitor your patient. So regular monitoring will be urinalysis. So we can simply ask for at each visit, for instance, the doctor will ask for a urine sample, and we will check for microalbuminuria. So these are protein molecules that leak into the kidneys and are present in your urine. So this is an early indicator of decreased compliance. Decreased compliance meaning it's a decreased ability to compensate. Okay, so this is an early warning detector. So of course, this is present before the patient actually goes into failure. All right, so again, it's like this. So the patient is in heart failure. There is no cure for heart failure. There are causes which we discussed last week. There's a list here. Table, what was that? Table 45-1. So these are the causes and risk factors for heart failure. So this is what I'm saying, there is no cure for failure. Once you're in that state already, meaning the patient's heart is already damaged to some extent due to these causes right here. So even if you treat these causes, doesn't cure heart failure. Right? So some of these can be like hypertension can be managed, diabetes can be managed. Okay, you can stop smoking, right? So you can stop smoking crack. We can repair the valve that caused the problem. We can treat the infections or inflammations. We can surgically correct the congenital defects, right? We can manage the dysrhythmias. We can treat or manage the hyperthyroidism or Graves' disease. We can make the patient lose weight, right? So we can manage the lung disease. Once damage is already done to the heart, and patient goes into heart failure, the only thing you can do is now just maintain it. There is one cure, I think I mentioned it 2 weeks ago, you get a new heart. Well, there is no new heart. You get a recycled heart from somebody else, right? So that's the only cure per se. So there is a cure, but it's a transplant, right? But the existing heart that we have, which is already in failure, there's no cure for that. So you can only manage. So as long as the patient complies with the treatment, with the
Professor, you're breaking up a lot again.
okay. How about now if I stop my video?
It's better when you stop the video. That's what I was trying to say before.
Yeah, that happens with our clinical professor, so she just doesn't do it.
All right, so I'll try that. Okay, what did I say? What was the last thing I said?
So there's no cure for heart failure? It's the last thing I
So
said.
did
You
get
could
that
do
part correct.
transplant.
All right, so yeah, so heart failure is a chronic condition. There will be periods of exacerbation, meaning there will be periods of decompensation due to, let's say the patient gets sick, gets the flu, for instance, so therefore whatever treatment we were giving the patient will not be adequate given the additional stress placed upon the heart. So maybe there's a severe emotional stress that the patient is undergoing, is dealing with. The patient may also have let's say during the holidays, okay, so the patient celebrates as we all should. They're not supposed to have a lot of salt, but it's Christmas, it's my birthday, or it's St. Patrick's Day, right? So we get additional alcohol, extra salt, a lot of sausages, for instance. So the patient will decompensate, all right? So It doesn't mean they'll die, but of course that will require now hospitalization, because again, the treatment that we do every day will of course be inadequate to deal with the heart failure during an exacerbation. Right? So we looked at the microalbuminuria. That's why this is again an early indicator. Okay, so before the patient actually shows those signs and symptoms listed in charts 35.1 and 35.2, the albumin will be present in the urine. So this can be done outpatient. So this stated here, this lets the primary healthcare provider know exactly the early signs that, oh, my patient is Mr. Smith, you're about to have a decompensation episodes, or good thing we saw you today, right? So you need to increase your, so he'll write additional prescriptions, and then stay off the, whatever you're doing, okay, stay off the salt, all right? Or let's say, stop, you see your wife told me you're smoking again, okay, so stop that. Or we treat, let's say it's an upper respiratory infection, maybe the patient is having the flu, all right? So this can be an early warning detector. Another set of labs that will be drawn are a thyroid panel. Thyroid, hyperthyroidism, and hypothyroidism will be discussed in your 5th semester. And this is one of the causes also. In fact, this was listed in table 35-1 as one of the causes or risk factors for heart failure. ABGs are used more so during an exacerbation, meaning if the patient is hospitalized, then we draw ABGs, just to determine the extent of the damage on perfusion. Imaging assessments, we can do X-rays. X-rays will just tell us the shape of the heart, how bad or how long has the heart failure been. Okay, it will show any remodeling, meaning the heart may have changed shape in response to the failure. You'll have cardiomegaly or enlargement of the heart, meaning remember the stretching. So there is chronic stretching of the ventricles, of course, that will cause the ventricles to enlarge. However, it doesn't mean it's necessarily stronger. Okay, it's just overstretched. Right, so that causes hypertrophy or dilation, which is not good. Meaning, if you dilate something, that means the walls are now thinner. Okay, not necessarily stronger. It's not like skeletal muscles. All right. So if it's dilated and hypertrophied, of course, that will weaken the heart, which is a common finding in heart failure. I won't test these expensive tests right here. Cardiologists may order them. They are really very expensive tests, but won't tell us really anything new. Well, at least that's my opinion anyway. You can still evaluate heart failure by other means. That doesn't need to be these expensive, complicated testing. ECGs will only show because the patient, of course, in heart failure can develop AFib, so they will use ECGs to see if, because whenever you have pooling of blood in the heart, especially in the atria, that will cause pressure in the atria to increase, causing or triggering the development of atrial fibrillation. However, as stated here, it is not helpful in determining the presence or extent of heart failure. Meaning, it's just something we do in order to see what complications have resulted from the heart failure. Okay, so we're checking for dysrhythmias. Before we move on, I'll go to chapter 38 to explain invasive hemodynamic monitoring. When we say hemodynamic monitoring, so hemo is blood and then dynamic is changing. So this is invasive hemodynamic monitoring. So instead of checking the patient externally, like checking the blood pressure in the arm, or checking your pulse ox in your finger. Okay, these are all external monitoring devices. So hemodynamic monitoring is internal. So this is used. This is done using a pulmonary artery catheter to measure pulmonary artery pressure, or pulmonary artery wedge pressure, or right atrial pressure. Okay, so here we're monitoring right atrial pressure and pulmonary artery pressure. Let me explain these and why it's important. So it's taking us to chapter 38. Before that though, I'll show you a short YouTube video.
This is a demonstration of.
Can you see the YouTube website?
Yes.
Yep.
Yes.
Okay. All right. So this is the catheter is called the Swan-Ganz Catheter. It's a pulmonary artery catheter named after this guy, Edward Swan-Ganz. He invented it as well as the technique. So this is inserted inside the pulmonary artery. So the purpose of this is to monitor pressures inside the heart. So this is way better than monitoring it outside. This is only reserved for really sick patients. So if a patient in heart failure is going to shock, for instance, then the doctor will put in a catheter. It's invasive, of course. That tells the number one complication. You already saw chapter 13, central lines, sepsis, right? As the most life-threatening complication. So the same for a Swan-Ganz catheter. It's invasive. It's put inside the heart, unlike a central line or PICC line, when the tip of the catheter was in the superior vena cava, right? So this one is inside the heart itself. So the purpose of the catheter is to monitor pressures inside. So therefore, we see the changes real time inside the heart. So rather than waiting for this patient to manifest those signs and symptoms listed in chart 35-1 and chart 35-2, this will occur sooner, meaning the patient doesn't even have symptoms yet, but we can measure what's happening inside the right side and the left side of the heart. So therefore, if those pressures change, that's the earliest opportunity you have to adjust your treatment before the patient even shows symptoms. So therefore, the patient outcome, of course, will be much better because you're able to treat the patient sooner using this internal monitoring device. So I just want to show, we're not inserting this, the doctor inserts this at the bedside, but I just want you to see where it is.
Look for that.
Okay, so if you're wondering how did this end up here in the right atrium, so this is inserted here on the neck. So this is a catheter, like the Foley. So the only way this thing will go is because, of course, there's blood going in and out here, and the heart is beating constantly. So it's not always a very successful okay, I'll answer the question on the chat shortly. Okay, so this one is inserted in the neck. Again, it's a catheter. There's no wire inside it, so it's like a limp noodle, right? So the only way this will travel, because our objective is the doctor wants to put this here, right here on the pulmonary artery. There will be 5 lumens here, meaning this one will have, it's one catheter, but it will have 5 openings, okay? Meaning there's 5 catheters, if you want to look at it that way, inside one big catheter, right? So it's it has 5 lumens. So one of those lumens will monitor, I forgot the color. So there, it's color coded. So it tells you, plus it's labeled anyway with which lumen you're accessing. So one will be will measure right atrial pressure. Right atrial pressure meaning if this is the septum right here dividing the patient's heart into the right side and the left side. So the right atrial pressure will of course tell you the pressure in the right side of the heart. And because the PAP catheter, the other lumen, which is at the tip of this catheter, there will be another hole here at the tip, will stop right here. So therefore, it's on the left side of the heart, although we didn't put it in the left atrium or the left ventricle. But however, since this is the lung right here, so you have the lung over here, another lung over here on the right. So whatever's happening in the lung, so let's say there's congestion in the lung, it will of course be reflecting directly on the pulmonary artery, meaning whatever happens in the lung will be reflected on the left and the right pulmonary arteries. Meaning if there's congestion in either lung, it will be picked up by the pulmonary artery pressure. So therefore the pulmonary artery catheter, the tip, which is right here, will indirectly measure pressures on the left side. Meaning whatever happens here on the left side, as you saw in chart 35-1, will reflect on the lung, and then vice versa, or as a result also. So whatever happens there will also be reflected on the pulmonary artery. Are you understanding so far?
Yes.
All right. So meaning it's impossible to put this catheter inside here. I mean, how? Right? You put it here, there's no way it's gonna go through the lung and then go back here. Right? It's impossible. So we're happy with an indirect measurement of the left side. Okay. So the doctor inflates the balloon, and the tip will be so he'll inflate it with either saline or air. No, saline only. Sorry, not air. So it'll be inflated with saline. So now we have a balloon, inflated balloon. Again, there's a pressure. It will pick up pressure because there's a hole here at the tip, which is connected to the transducer. So it picks up pressure in the right atrium, and then look at the pressure when the balloon entered the right ventricle. So pressures rose, and then continues. Okay, when it enters here, the pressure will change again once we hit the pulmonary artery. So here now we have a pressure change. It's slower compared to the right ventricle. And then when it wedges here, right here, so there's a wedge because now we have obstructed the pulmonary artery. So the doctor knows where he is, so he's now going to deflate the balloon and then pull that back a little bit so the pressure changes now. So now that is perfect right there. So it'll stop right there, and that's where the artery, pulmonary artery, is going to be staying. So there will be two. There's one hole here, another hole here. Both of these will be measuring pressures. So this one will be and this one will be connected to a pressure transducer, monitoring the pressures on the left side indirectly, and then directly the right side heart pressures here. Okay, so to answer the question on the chat, I did see who asked it. By the way, we will not be discussing left ventricular assist devices because these are advanced cardiac equipment used for really bad patients, wherein it's now, there are also invasive devices, but they're therapeutic though. They're not used. This one is simply used for diagnostic purposes, for us to effectively treat and evaluate that responds to our treatment. All right. As already mentioned, there are alternatives though to putting this in, because there are complications during insertion. Because again, this is a very limp noodle. It will possibly just coil and then bounce around here, causing a dysrhythmia during insertion. Okay, so it's not always smooth like the animation shows. So there, plus this one, of course, you know, the valves here open and close, so the presence of the catheter will, of course, make result in a non-complete closure of the valves, because they'll technically stay a little bit open because the catheter is in there. However, all the other methods that we could potentially use though, like the one suggested, what was the exact question? Okay, the maps provided by other methods is not as good as a pulmonary artery catheter, because this one is measuring the pressure directly inside here. Meaning there are other methods besides this. Mostly younger doctors use that method. The old school doctors still put in Swan-Ganz catheters because they are really simply the best pressures you can get. Right? They have the most accurate measurements, and it's not really a the correct word is it's not a definite science when they use other methods and then just use certain formulas to calculate the pressures inside. They can use Dopplers, for instance. They can even use ultrasound to do the same, but again, it's not an exact science, unlike the pressures provided by a Swan-Ganz catheter. Anyway, so that's again, this part here is not testable. Okay, I'm just trying to explain to you where it is and why the pressures would be like they are. So we'll come back to 697. I'll bring you to chapter 38 shortly. 697, I think it's 780. I don't want to just all right, so here is hemodynamic monitoring. So how is this asked on the exam? All right, let's see if you understand what how the pressures are used. Okay, so right atrial pressure, because this is the hole in the catheter in the Swan-Ganz that is on the right side, therefore this one will be measuring right side heart pressure, whereas the tip of the swan is at the pulmonary artery, so therefore that is indirectly measuring the pressure on the left side of the heart. Now these are the normal ranges. As you can see, it's 2 to 6. Some books will say 1 to 8. Don't worry, I will not let you choose between 1 and 2 or 6 or 8, right? So it'll be either normal or really high or very low. Same thing for the pulmonary artery wedge pressure. So we will use 4 and 12 millimeters of mercury. All right, so let's review and apply this to chapter 11. So Miss Brittany, Miss Bowman,
Yes, Professor.
All right, so if you're having diarrhea 16 times in the last hour, what will your right atrial pressure most likely be?
It may increase. Or
You're
decrease.
having diarrhea, like explosive diarrhea, 16 times in the last hour.
It would decrease?
All right, because do you have enough blood volume in you?
No,
No.
it's being excreted out.
Right, so therefore what happens to your preload?
The preload is going to decrease.
All right, so therefore less blood volume overall. So the pressure in returning, the blood volume returning to the heart is considerably low. So therefore your right atrial pressure will be low.
It's low.
What about your PAWP? What about on the left side?
I mean, I feel like it will also be decreased because the blood volume is low. So that means
it's the same blood volume, correct?
Mm-hmm.
Right. All right, so let's say you got admitted to the hospital and then I am your nurse. So I was busy, I was preoccupied. It was battle day for Clash of Clans, so I was distracted, okay? So it was a close fight, so I was busy online and I was scolding my teammates, hey, get your attacks in, hey, we're losing. So I did not know, I did not know that my fluids were running at the wrong rate. So I was supposed to give you 250 mLs per hour. I put in 500 mLs per hour. All right. So you got more than double the ordered rate. So this went on for 8 hours. Okay, and I just kept hanging bag after bag on the IV pump, right? So now are you still dehydrated?
Are you asking me, Professor?
Yes.
No, you're not dehydrated because they're giving you the IV fluids.
All right. So are you
You're gonna
in
have more
deficit,
fluid.
normal, or overload? If I was giving you more than double.
Overload.
Okay. So now, what will your RAP be?
Higher.
What about your PAWP?
That will be higher as well.
All right. Very good. So any question on how this is applied?
Yeah, I have one question, Professor.
Go ahead, sir.
So if one increases, is the other always going to increase with it, and vice versa?
Depending on the cause. So in that example, it was the fluid volume overall, right? So they were both high. But if I ask you, if a patient in your care is having right side heart failure, specifically right side, which one of these numbers will be high?
RA?
Your RA will be low and the other one will be high?
Again, the right side is failing. Right? The right ventricle is not pumping effectively. We have no idea what's happening on the left. All the data you have on the question is that the patient is in right side, is in right ventricular failure. So therefore, what will you see on the right atrial pressure? It's someone with right atrial failure, well, right ventricular failure.
It would decrease.
So the blood in there isn't moving because the right ventricle.
Oh, okay. All right. So then that would increase. Okay. I follow
right.
now.
So that's why this italicized statement here says it will be increased with right ventricular failure. However, in the case of Miss Bowman, who was having diarrhea, it will be lower.
I got you. All right. Thank you.
All right. So let's go now to the other one. So Miss Manera, if the patient is in left side heart failure, what will be PAWP or PAOP be? PAWP.
To be honest, I'm not really sure. I'm trying to figure this out right now.
Right, so the patient had a heart attack
Okay.
involving the left ventricle. So now is the left ventricle pumping effectively?
No.
So what will happen to the PAWP?
Increase
Why?
because it's not pumping as effectively. So the pressure would be high.
Right, so therefore, right, so the blood is just sitting there on the left ventricle.
Okay.
Right? Okay. So would you like to see these, or would you like to see? Would you like to wait for what? You know what? I'll wait for crackles to appear. I'll wait for urine output to drop. I'll wait for um, weight gain. I'll wait for peripheral edema. What would you rather have for your patient?
I'd rather not wait.
All right. So I'd rather have my patient have a Swan catheter, a Swan-Ganz catheter, telling me exactly what's happening rather than waiting for, because you know how long it will be before peripheral edema appears? The patient will have to at least retain 4 liters of fluid, at least 4 before you see pedal edema, meaning that's a lot of water retained. That's a lot of urine that should have been eliminated. Right? That's a lot of water that should have been normally excreted in the kidneys, but it's not because your patient's heart is failing. Okay. And then the crackles in the lung, it's not always successful that the patient may have after you give diuretics and then everything is good all of a sudden. Not all the time. It really depends on how long has it been there. The patient may go into respiratory failure, which is another problem.
Okay.
All right.
Thank you.
Okay, so any question on hemodynamic monitoring? Again, it's not very popular among younger doctors. The new generation of doctors use something else now. But all of them will agree that as far as accurate measurements go, there's nothing close to the Swan. Again, the Swan-Ganz is not the safest either.
Is this chapter 23, Professor?
What?
What chapter is this? Chapter 23?
No, I'm going back to 35. Trying anyway. right, so that was hemodynamic monitoring. Let's go now to our interventions. For cardiac problems, they're usually medications. There's not too many nursing interventions per se. I'm talking about independent nursing actions. One is positioning, one is to decrease oxygen demand by putting the patient in bed. They'll be on bed rest for a while, but not too long. We do encourage them to be out of bed, but during the acute episode of an exacerbation, of course, you want to decrease oxygen demand, okay? Because the more this will not be the time to ambulate this patient, right? It's not a good idea. So you give oxygen, which is again a dependent order. So this is why I'm talking about there's really not much a nurse can do independently. We need medications, okay? We need doctor's orders here. So number one, of course, is to give oxygen.
Professor, I'm sorry. Are you supposed to be sharing your name?
Okay. All right, so I'm back to 697. So first thing is to give oxygen, and then you monitor, of course. We start with oxygen low. Unless the patient's oxygen saturation is very low, then you go higher. Our aim here is to maintain SaO2 90 or better. Position will be high Fowler's, with pillows if possible. Remember, these patients are orthopnic. Okay, they cannot breathe laying down flat. So we do encourage coughing, deep breathing exercises. So you can read, right? So these are your interventions during the acute episode. And then comes our medications. So again, we go back to the 3 elements of perfusion here. So we want to improve contractility of the heart. We want to decrease preload. We want to decrease afterload. So these are the purposes of your medications here. The following paragraphs that follow table 35-3 are all about these drugs. So for our purpose, we will use an acronym to make this easier. We will use doables. The drugs here are really the DUAP. So here we have diuretics. Then we have digoxin. This one's oxygen. This one is ACE inhibitors or angiotensin receptor blockers. Then we have beta blockers. And we also have BNP. And this low non-pharmacologic now, low sodium diet. This is exercise. And this is smoking cessation. All right, so we will eliminate the expensive ones, like this one. I'm only testing the common.
Professor, your screen is frozen. I don't mean to interrupt you.
Oh, well, it's supposed to be frozen.
No, I know. Like, were you clicking on anything though? Because I know you said the doables.
Oh, okay. So it'll be a different share. Sorry. You're right.
Thank you.
Should have been this one. All right. So here, not that one. All right. That should be it. Nitrates will also be included, but they're not used in heart failure. It's more in dysrhythmias or in acute coronary syndrome. So just these here. So there is a human BNP. This is the one here. This drug is nisiratide or natricor. And then we have different diuretics. We have side loop and spironolactone, your potassium sparing. And then we have the toxin right here, which is your inotropium. Then we have, that's oxygen, and then we have ACE inhibitors. This one here is a combination of both. So you have an ACE inhibitor and a ARB. That's a new drug called Interest. We have your OLOS, BNP, right? So diuretics definitely will lower preload. Hold on a second. The will tell you exactly what they do for each one. Right? Let's start with those. I won't read the whole thing for you. You have to read it yourselves. We'll start with drugs that reduce afterload. So ACE inhibitors and ARBs both have impact on the renin-angiotensin system. So they cause, of course, vasodilation, but not the same effect, not the same extent of vasodilation caused by nitroglycerin, all right? So they're not, you can say they have a combination of course, they will stop the renin-angiotensin system. So therefore, there is no aldosterone secretion. Therefore, and also no conversion of angiotensin 1 to angiotensin 2. So therefore, no vasoconstriction. Because remember, earlier on in the chapter, here, whenever cardiac output drops, it will automatically trigger these responses, right? It will trigger sympathetic nervous system, which increases heart rate, causes vasoconstriction, and the renin-angiotensin system also causing vasoconstriction and also increase volume because of aldosterone. So we want to stop all these. This is not good for a patient in heart failure. So that's why our drugs are, some of our drugs will be used to stop those compensatory responses. So for for ACE inhibitors, because exactly how they work is to stop aldosterone from being secreted. So therefore, no aldosterone. That means sodium is lost. However, potassium is retained. That's why your number one complication is hyperkalemia. So this will now mean whatever you learned in chapter 11 for management of hyperkalemia, which is to remember that chart with the foods high in potassium. So that will come in handy again for exam 2, because now you'll have to teach the same drugs now this time to avoid when the patient's taking an ACE inhibitor. So that's on top of the cough, the nagging cough that will also accompany ACE inhibitors, because they trigger bronchospasms. So that's why they're, if a patient has a hacking cough, we'll have to change to an ARB instead. All of these drugs, though, of course, they lower blood pressure. So it's a given that for each of these patients, you teach them to get out of bed slowly, then go first, watch for orthostatic hypotension, especially if they're new to the drug. So always monitor them for those. So here's a drug alert for both of those drugs. Here is Nisiratide or Natricor. And this has diuresis and vasodilation effects. So therefore, that's why it falls under. Actually, if you think about it, it has both preload as well as afterload decrease. Here's a drug alert for Niserotide. And then for preload, let's start with non-pharmacologic nutrition therapy. So this will be for sodium restriction. There are 3 levels of sodium restriction depending on the patient's heart failure severity. If it is no added salt, this is the easiest one to tolerate because you simply don't add salt to your, meaning no table salt. Okay, but doesn't mean you can't eat salty foods. Okay, so you're still limited to about 3 grams, which is not bad. 3 grams, there's some taste to your food. Okay, so your food still tastes good at 3 grams. 3 grams though is daily, right? So you have to be mindful of how many meals you take, and that means they can't go over 3 grams a day. So that's what no added salt means. We can go further. This time, you absolutely cannot eat foods that are naturally high in salt. So all salt in cooking will also be eliminated. So you limit it to just 2 grams. Now this is now pretty bad. If you look at your chips, for instance, or any label on the foods you eat, okay, so you see the amount of sodium there. So imagine if something only has 2 grams, but that's not for 1 meal though. That 2 grams is all you get for 24 hours. So you'll have to be creative with how you flavor your food here without salt. There are salt substitutes, but be careful, especially if you're stingy. Let's say you're cheap. You don't want to pay a few dollars more for your salt substitute. Most cheap salt substitutes use potassium instead of sodium. So that can be contraindicated if the patient is taking what drug? Hello? ACE inhibitors, right? So if the patient's taking ACE inhibitors, they have hyperkalemia because of the drug, so therefore they cannot use salt substitutes. Fluid restriction. Usually not everybody is put on fluid restrictions. Only hospitalized patients usually are fluid restricted. At home, because of course the patient's at home, so that means they're pretty stable. There's really no need to, most doctors don't make patients' lives more miserable by restricting fluids, right? They just allow them to drink whatever because they're on diuretics anyway. So only hospitalized patients, usually we put them on a 1 liter fluid restriction. You know this already. We discussed this extensively in chapter 11. How much is 1 kilogram weight gained or lost? How much fluid is that equivalent to?
1 liter.
What about if they gain or lose 1 pound?
That's 1 liter lost or gained.
1 pound.
I think it's 0.5.
500 milliliters, okay, or 0.5 liters. All right, so we did nutrition therapy for preload. This is now the drug therapy. So number 1 is, of course, diuretics. We have 3. Like I said, we have loop, we have thiazide, and we have potassium-sparing diuretics. Please read all the details as well as the this patient-centered care box here. Again, this is the opposite. So if it's ACE inhibitors cause hyperkalemia, thiazide diuretics and loop diuretics cause hypokalemia. And remember, these patients are also on digoxin, so therefore this can lead to digoxin toxicity. For spironolactone, of course, that is a potassium-sparing diuretic right here. This one will also cause hyperkalemia. So the same teachings pretty much as those with ACE inhibitors. And here's a warning. Which organ of the body eliminates? How do we get rid of potassium again in our body?
Kidneys.
Kidney.
All right, so 80% of your body's potassium is excreted by the kidneys. Only 20% is excreted in the GI tract or through the sweat. So therefore, if you have kidney failure, as is what happens here, meaning this is your evidence, your creatinine is high, so that means there's kidney injury. Do not give any potassium before you do that. We did discuss this in chapter 11.
Yep, kidney, it's water, it's fluid retention, right?
I'm sorry?
It would cause fluid retention
What will cause fluid retention?
if the kidneys fail.
Yeah, but yeah, that's true. But we're talking about potassium here.
No, but so wouldn't it increase that, the levels?
Yes, meaning the patient can't get rid of the potassium. So always, what do you do before giving any potassium supplement?
Check the levels.
Levels of what?
Check the kidney function.
Kidney function. I know you were gonna say also potassium levels, right? Yeah, that's true also, but you should also check kidney function. Here's the nitrates. Again, the patient with heart failure isn't routinely given nitrates. It's usually for acute coronary syndrome. So this will be in chapter 38. This one though, well, we will test this again in chapter 38, but whenever you're giving nitrates, because they're given constantly, especially if it's given through the skin, meaning we're using ointments, the patient does develop tolerance to the drug. So therefore, it should only be on for 12 hours and then off for another 12. Right, so that's what it means here. To prevent tolerance, the doctor will prescribe a 12-hour nitrate-free period, meaning for 12 hours, the ointment will be on, the nitroglycerin ointment will be on, and then it must be taken off. It must be rubbed off the skin for the other 12. All right, this is only true though for the topical ones. No problem with the oral, like isosorbide is oral, that's no problem. And finally, so we did drugs that decrease preload, decrease afterload. Now we try to enhance contractility. There are several drugs, but for our purpose, we are doing entry-level nursing only. We will only discuss and test digoxin. This is the most, the cheapest drug out there. Everybody's on digoxin. Just make sure though that this is only given for chronic heart failure, meaning a patient who is in acute heart failure must not be given digoxin. The reason is the drug is an inotropic agent. While it increases contractility, it also makes the contraction stronger. And whenever we do something stronger, that means it's also going to cause increased oxygen demand. So therefore, it's not given for a patient in acute heart failure. Digoxin is only given as a maintenance, meaning this is only given for patients every day at home. Are we clear? So if a patient is in acute decompensated heart failure, we do not give digoxin during that period. Okay, we wait until the patient is better before we resume digoxin. So these are the effects of the drug. It's this one that really causes increased oxygen demand. Okay, so the more, the greater the force of the contraction, then the more oxygen is actually also consuming. Although it does decrease the heart rate, so that kind of compensates for it, but not during the acute episode. Okay, so this is only for chronic heart failure. We'll discuss toxicity next. This is one of the side effects of the drug. Because it slows AB conduction, meaning the impulse from the SA node to the AB node. We will discuss that in chapter 34, 5th semester. This can cause dysrhythmias, specifically bradydysrhythmias like heart blocks, for instance, or sinus bradycardia if the patient's lucky. But usually this drug has been associated with terrible dysrhythmias. You'll learn those when we go to chapter 34. So although digoxin is nice, its effectivity and its benefits is now being questioned. However, we're still seeing digoxin in our textbooks. So until it is taken off the market, we will continue to test it, and people will continue to take digoxin. Here is the danger. So remember, these patients are on several drugs. So you saw the doables, so DUAB, we have diuretics and digoxin. So that combination alone, especially if you're taking loop or thiazide diuretic, which will cause hypokalemia, correct? Now, the only way digoxin enters the cell is via the sodium-potassium pump. That's not listed here, it's listed only in pharmacology. So if you read your pharmacology book, digoxin enters the cell via the sodium-potassium pump. So therefore, it needs potassium in order to enter the cell. So if a patient happens to be taking thiazide or especially loop diuretics, which cause hypokalemia, can it enter the cell with less potassium? No. So therefore, what will digoxin do? Where will it end up?
In the blood?
In the blood, causing toxic levels. And your signs and symptoms are the following: anorexia, fatigue, blurred vision, changes in mental status. Others are bradycardia, of course, because now you have high levels of digoxin that will drop the heart rate considerably low. Other symptoms are also nausea, vomiting, and abdominal pain. But these are what's here. Another cause of digoxin toxicity or any toxicity of any drug actually is kidney failure again. So if a patient has either acute kidney injury or chronic kidney disease, they are also at risk for digoxin toxicity. Because again, all drugs are eliminated by the kidneys. So no kidney function, you'll have toxic levels of any drug. In heart failure, the patient's desirable heart rate is between 50 and 60. This is where the doctor wants it to be. So therefore, do not be alarmed when a patient's heart rate is below between 50 and 60. All right, so it's actually beneficial, meaning the lesser the heart has to beat, the lesser the oxygen demand, the lesser the cardiac workload. However, we still have our parameters, meaning unless the doctor specifies it, your drug book, so your nursing handbook and your pharmacology book tells you that for beta blockers and digoxin, the cutoff heart rate is always 60, meaning you can only safely give the beta blocker, because beta blockers, of course, lower heart rate. Digoxin lowers heart rate. Our cutoff is 60. So before giving the drug, you check the apical heart rate. If it's 60 or more, then you can give the drug. Don't think that, oh, it's already 60, I shouldn't give it, because of course the heart rate will drop. But that's fine. That is our desired heart rate. We don't worry about that. We do worry if it's already below 60 to begin with. And of course, you have a different order, right? So in the absence of a doctor's order, we follow the drug book. And the drug book says, if your heart rate is below 60 for beta blockers, calcium channel blockers, digoxin, which all lower heart rate, you must hold and call the doctor. What do we do again if it's below 60?
Hold it.
Hold it.
That's not what I said.
Call a doctor.
Hold and call the doctor. Okay, holding it is not enough. It should be, what's the answer?
Should be recorded as well.
All right, hold and call the doctor. It doesn't stop at hold. Meaning, my point is, why is the heart rate low? Why is it low in the first place?
Yeah, that's unknown.
All right, so you need to notify the doctor. That way the patient stays safe. Because what if the patient, let's say it's digoxin, what if the patient's already in digoxin toxicity? That's why the heart rate was below 60 to begin with. Yeah? So again, the answer is hold and call the doctor. Unless of course you don't have any other choice on the test question. If the test question says no, everything else, but there's no call the doctor, then of course you'll have to only pick the holding the drug. All right, but if you have the choice between the two, yeah, I would still go with holding and then calling the doctor. Besides, it's not within our scope of practice to hold something. Right? Of course, you won't give the drug, but legally, you need an order to hold it, right? Yes? No?
Yeah.
Yeah.
So you'd say call the doctor first then.
No, of course you don't give it. Yeah, of course you don't give it, but you can't
you
stop
just said
there though. Yeah, because the order was to give it, and then you decided not to give it using your judgment. So you need an order to legalize what you did or what you did not do. Okay, you need to support that. Yeah, because again, you're a nurse. We can't stop. That like I'm not giving that. Period. No, we can't. Because the doctor listed it on the orders. It's listed on your MAR that you give it every day. But since you're deviating from that order, you need an order to make it legal. All right, that's all I'm saying.
Thank you.
Okay, so this is what I said earlier about digoxin. So any drug that increases the workload of the failing heart also increases oxygen requirement, which is what digoxin does. Because remember, it says here, it increases the contractility. Right, so therefore increasing contractility increases its contraction, its oxygen demand is also increased. Okay, so watch for possibly chest pain. We will not test the other inotropic drugs. They're not very common. Plus, I've never tested them, and there's never been a problem on NCLEX. Nobody's come back, oh, there was a question on milrinone or something, right? So we're okay as entry-level nurses. Beta blockers. So of course, this is a beta adrenergic blocker, so therefore it will stop or block the adrenergic symptoms, which is the epinephrine or epinephrines, or simply put, the sympathetic hormones that are triggered when heart rate or when cardiac output drops in heart failure. So we stop the increasing heart rate and the vasoconstrictive effects of epinephrine or norepinephrine. You have your details here. So same thing with the digoxin. So this is our goal, right? So as long as your heart rate is 60, you give the drug. If it's under 60, what do we do again?
Call the doctor.
Hold and all right. So don't worry about the heart rate being 60. Although I know you're gonna think that, oh, if I give it at, even if the heart rate is 60, if I give this drug, it's gonna drop it. That's fine, because our target is 55 and 60. Or in the case of the digoxin, it was 50 and 60. Right. So as long as it's 60 or better. We'll skip this also, so we'll just do the beta blockers. And here's a warning here: do not confuse succinate and tartrate. They're two different drugs. It has something to do with the how they're released. Okay, they're not the same drugs. They're not interchangeable. So if you have tartrate on your drawer, on your medication drawer, and you have succinate ordered, they're not the same. Plus, it won't the EMR won't let you proceed anyway. All right, we'll do Cpap, and then I'll give you a break. Cpap is not a drug, obviously. This is used for sleep apnea in patients with heart failure. So it has two effects here. One is to improve sleep apnea. The other is actually decreasing preload and afterload. Now, they do so by, when you have Cpap, this is positive airway pressure. So therefore, it will, even at the end of exhalation, there is air being pushed. There is positive pressure being pushed in your airway. So therefore, the lungs, technically, the pressure inside the lung at the end of exhalation does not go to zero. So if you imagine that, the lungs do not completely deflate at the end of exhalation. So therefore, if you imagine the normal cycle, let me illustrate it. So if you imagine if this is your normal breathing, so let's say you take a deep breath, that's what normally you breathe. Okay, this is the peak inspiratory pressure, PIP. And this inhalation, and this is the end expiratory pressure. So the heart is here, then you have the lungs here, right hand side. So they share the mediastinum, and this is your chest. So the peak of inspiration right here, and these pressures right here, what's happening at the peak of your inhalation? Since they share the same thoracic cavity, and the heart is in the middle of these lungs. So during peak inspiratory pressure, right here, this is zero pressure, this is zero pressure, and this is the highest pressure. So what's happening? What are the lungs doing to the heart during peak inspiratory pressure?
Squeezing it?
What happens to venous return during this period here? This is only, I don't know, 0.2 seconds maybe. What did you say? What happens to venous return?
I don't know. I said increases, but I don't really know.
No, you said the heart is squeezed, right? So what happens to the vessels are here? Do you have the superior vena cava there, inferior
More
vena
pressure,
cava?
right?
Yeah, so what are the lungs doing to the heart and the great vessels during peak inspiratory pressure?
Squeezing it? Pumping it?
When you squeeze them, what happens to venous return? Blood returning here, blood returning from there. What happens?
It'll decrease.
All right. So therefore, what happens to preload during peak inspiratory pressure?
Decrease?
Decreases preload. Does that benefit a patient with heart failure?
No.
Nope.
What have we been discussing this whole time? What was the purpose of our drug therapy? Are we increasing or decreasing preload and afterload?
Increasing.
All right, so question again.
So it would
How
help.
does this, okay, this actually helps because if we prolong the PIP, I mean, not that this pressure, you know? So what I mean here is, so let's say it's like this. So if you have Cpap, we won't go to 0 right here. At the end expiratory pressure, it won't go to 0. It will be, just draw right here. So let's say it will be like this now. So if this is 0 right here, so if you have Cpap, it won't go to 0. There will be maybe, I don't know, 6 centimeters of water pressure. So unlike here, wherein the pressure returns to 0, starts 0, returns to 0, this one here does not go to 0 because you have Cpap, you have positive pressure. So it will just go like this. Okay? But it doesn't go to 0. Thereby, I mean, it won't stop all the preload. I mean, it won't completely stop venous return. It will simply just decrease venous return. So therefore, to a certain extent, it actually helps decrease preload, right? So double-edged sword there. So you can have apnea because sleep apnea causes increased afterload because there is now, if let's say patient has sleep apnea, so it's not breathing. So is it hard or easy to pump blood to the lungs? If a patient has any pulmonary condition.
Can you repeat that? You're cutting out a little bit.
All right, so what I was asking is if a patient has sleep apnea, COPD, or any other lung condition, is it easy or to pump blood to the lungs?
Harder.
It's hard because the circulation there is higher, meaning there is hypertension, there's pulmonary hypertension in any of those disorders. Sleep causes pulmonary hypertension, COPD does that, asthma does that. So therefore, if you you make breathing easier, you also decrease the amount of resistance inside the lung. So therefore, they decrease, therefore, afterload and preload. Okay, so that's how CPAP benefits your patient in heart failure. All right, let's return after 15 minutes. So that's 9:56. No, my math is bad. 9:51. All right, see you at 9:51.
Okay.